So our first panel of the afternoon is community motivation and in action testing. So the first person is promoting alternative HIV testing to undiagnosed population. And that's Friday. And I just have O as the last name. And he's from SERC. Brandon. Is Friday there?
Yes.
Oh, okay, you're on
Thank
Friday.
you, Ken.
I'll let you know when you're at your 9 minutes.
Okay.
Go ahead, start.
Okay. Yeah, good afternoon, everyone. I will be very quick because I have a very limited time, and I will be talking about promoting alternative HIV tests to undiagnosed population. My organization, SERC, we're in partnership with Rich Nexus projects that we're trying to deploy the new rapid testing kit, instant testing kit across Canada, targeting the undiagnosed key population within our geographical space. And we're in partnership with them, and our location is one of the pickup sites, though there are various two alternatives to how we can go about it. Is either this is being delivered to folks at their various home address. So those are some of the things I will be talking in this slide. Most of you might have known what we are into at SERC. The only thing I added to it is the pickup location for I'm Ready HIV sex testing kit. Those are the new addition to the programming we offer at SERC, because we promote sexual health and sexuality education within the community and that we serve. So that's our website. So this is just a general overview of all what I'll be saying this within the next 10 minutes. All that I've been saying, credit is given to Rich Nexus and some of the personal experience as the go-to person at the SERC office in Brandon for folks that are signed up for the program, for the project, to partake in the research project to increase self HIV testing kits within the community. So we know that HIV is not a death sentence that is established, and since 1982, when we have the first case of HIV, and up to this moment, the whole world globally, we are still grappling with how to put an end to this global virus that has come to stay with us. And to what matter, we know that because of the COVID, a lot of attention has been shifted from this cause, and more attention has been given to a kind of emergency declare the health sector to focus more on the COVID cases. And now that things are returning back to normal, I think it is expedient that we go to return to the status quo and face these challenges that is facing every one of us. So what we know is that testing options available to date have not really met everyone's need. A lot of people are still going through the traditional way of testing, and the healthcare facilities definitely overstressed as a result of COVID, and inadequate attention given to HIV testing, which is a fact. And we believe that alternatively, that the best way we can go is to increase and promote this form of testing in our various spaces, so that people will be more aware, people will be able to to pick up this kit and know their status, and thereby we can combat this holistically together. So self-testing also, we know that breaks barriers and give people the choice to know their status on their own time. So this is where I'm Ready comes in, and the project was approved by Health Canada, and it kicked off last year, June, and we are still on it. We are in the second phase now. So I'm Ready is a national research and implementation science program that aims to give people in Canada, wherever they are, wherever they live, either in the rural community or in the villages or in any part of where they live in Canada, the opportunity to be diagnosed and to know their HIV test, and also refer to the pathway that may be closer to wherever they live. So we have the approximately 50,000 free HIV tests in the first phase, and we are now in the second phase of the project. Choice of delivery can either be through they deliver to your home address, or you pick up in one of the locations which SERC is part of. And actually in Manitoba, generally, we have about 8 different locations which can be picked up. So these are some of the things we are doing in our own little space in Brandon to make sure that we create awareness, to make sure we promote self-testing, because we have a lot of people that comes in, the blacks, the people that uses drugs, the indigenous, the bisexual, and folks like that. So they're working, and we try to encourage them to partake in this thing. So these are just the information on how one can use this test. Just like I said, it was approved by Health Canada, and it was launched last year. And the best thing about this testing kit is that it is very safe and simple to use, and you can do it at the comfort of your home and wherever you are, and you get your result definitely within 1 minute. So how to participate? We always refer folks to the website. There they have a lot of information, www.readytoknow.ca. And if you need further help, you can also link up with the peer navigators that are always available to peer with you to help you out in this. And you can get your results in either positive, negative, or invalid, depending on how it is being done. So these are some of the information that was shared with us in one of our quarterly meeting. We're made to understand that 25% of participants indicate that they are first time, which is encouraging, and 49% of those are under the age of 20 and first timer. So from the key population, we're made to understand as well in the meeting that about 45% of them are, when we are talking about the key population, we are talking about the Black and the CBI community. We are talking about the people that uses drug. We are talking about with men that have sex with men. So these are some of the composition of the key population. And as of today, in the last meeting that we had, we were made to understand that about 5 people have reported on the app to have a positive result. So positive HIV test result. So these are just like I said, 5 participants indicated a positive HIV test result on the app, which means that the I'm Ready program has identified 5 people who were previously undiagnosed with HIV, and now they have been guided and followed up to refer to the near local support clinic that will help them to move forward. So these are the major 5 identity and that were mentioned during those things. So based on my participation at the location where I am, I noticed some of these challenges which we try as much as possible to work on. So these are the noticeable challenges. We notice that there's still low level of awareness, and one of the reasons why I project this, I submitted this abstract for this conference is that all participants, we need to increase awareness wherever we are in our location, because I believe participants are cut across even Manitoba here and other regions. So I also noticed that a lot of folks could not participate in the research project because they don't have the mobile devices needed for you to be able to consent and participated in this and to participate in this project. So, and also folks also complain about inability to access internet. So we also provide our sites. In our site, we make it open that as many folks that are interested, we can also give them the opportunity to use our this thing to
You
yeah.
have 1 minute.
Yeah, I'll be done by then. So another thing that I noticed is that there's a lot of rural disconnection, which that is to say the rural areas are not well covered, and we need to work on that as well. So what we can do as a whole, as participants in this conference, we try as much as possible to promote this alternative initiative. We try to circulate, and if possible, we can donate our old mobile enabled devices to locations that are participating in this project, so that people that want to know their HIV status and don't have the mobile devices can also pick up those things, can be given out to them and for free, and use it for that project as well. So we also need to increase rural outreaches and educate more population to know their status. So interested participants can visit those www.readytoknow.ca. So conclusively, promoting this kind of novel idea should be the work of every one of us that is passionate about the work we are doing, about how to reduce or minimize this number, the cases of undiagnosed population in Canada, in our community, and create more awareness for them to know what to do, where to access this information as well. So we must all join hands to make this course a successful and a fruitful cause for every one of us and the community we live. So thank you.
Thank you very much, Friday. That was very nice. Lots of information, lots of hard work on your end. And with that, I am now going to move to the next person. And it is their title of theirs is Incorporation of Systemized STBBI Testing and a Community-based opiate agnostic treatment program. And this is Molly, Brett, and Chris Frays from nurses at Klinic Community Health Centre. And again, I'll be letting you guys know right around the 9-minute mark.
Perfect. Awesome. Can you guys hear me? Can everybody hear me? Yeah. Okay. Hi, I'm Molly Brett. I recognize a lot of names in the session today, so that's great. But for those of you who don't know me, I'm one of the primary care nurses at Klinic, and I'm also the program coordinator of our STBBI program at Klinic as well. So Dr. Andrew Lodge was also listed to be presenting today, but he's working in Grand Rapids, so he's not able to join us. But as Ken said, we're going to be talking about the incorporation of systemized sexually transmitted and bloodborne infection, or we'll say STBBI testing, in a community-based opiate agonist treatment program. And for that, we're just going to shorten it to OAT. So when you hear OAT, that's what we're talking about. And as you're going to see, this is a very big title for a very simple idea. So I'm going to pass it along to Chris.
Oh, and can you guys hear me?
Yeah.
Perfect. So yes, I'm Chris. Molly and I are 2 out of 4 of our on-site primary care nurses. We also have Jenny and Krista on our nursing team. Each of us nurses work primary care and also work an evening shift in our STBBI walk-in clinic, each do an evening throughout the week. And we each also follow clients on methadone and Suboxone on a regular basis. Rachel is listed as our manager, and Andrew is our doc for this particular, pilot project. So he's our lead on it, but we do have a number of other doctors and nurse practitioners on site.
Excuse me, your slides haven't advanced.
The objectives is where we're at right now.
I'm still seeing the intro slide. Maybe it's just me.
Oh. Can you
That's
guys see?
all.
Can you guys see objectives now?
No. I
No.
wonder if it's frozen.
Might be frozen. Yeah.
Let's try
Try
again.
reshare. Yeah. Perfect. You just click down to the. There we go.
There we go.
Yeah, you're not
We'll
in
do it
the
this way.
presenter mode, so that it's.
Okay.
Yeah, another thing is if you can also go to a full view, a slideshow, then maybe the clicks would work.
Can you guys can see the objectives now though? Maybe
Yes.
I'll just keep the screen like this. If that works.
That should work, yeah.
Thank you.
Okay, so the objectives for our chat today are to understand the possible intersections between STBBIs and substance use in our community, and to understand strategies to reduce stigma and systematize STBBI testing. Next slide.
In our practice, we've definitely been identifying an increase in STBBIs kind of across the board. And most of those are not being identified kind of by accident. Numbers are definitely going up for a number of them. And substance use is also on the rise and more identifiable, and has definitely been exacerbated by the pandemic. Next slide.
So we know with good evidence that when folks use substances, the risk of STBBIs are increased. Some possible examples of intersection are the method of substance use can result in infection. So for example, when folks might not have access to harm reduction supplies, higher risk behavior, whether that's voluntary behavior or non-voluntary. And we also know that there are barriers to accessing non-judgmental care, and there's a real fear of stigma. So those are some of the possible intersections there. Next slide.
So I know lots of us here are probably familiar with OAT, but stands for opiate agonist treatment. So it's a daily or monthly treatment that people with opioid addiction can take to help manage withdrawal side effects as well as cravings. These medications include Suboxone and methadone. We have a number of doctors who prescribe these medications at clinic. At this time, we're only offering OAT start and maintenance for our primary care clients. We don't offer services like RAMDU where anyone can kind of walk in and start those treatments. Our OAT clients are people that we connect with regularly, and typically we see on a monthly basis. Sometimes there'll be a disconnect or we won't see them for a while, or they'll be off treatment, but most of them do tend to come back. So yes, like I said, we see them on a monthly basis. If they're feeling like they need more support, we might even see them more frequently. Next slide.
Okay, so this is kind of the meat and potatoes. So towards wraparound care, systematizing STBBI testing. So really, like, our plan is not groundbreaking. It's not really rocket science. We're really trying to keep it simple, silly, or KISS is the acronym. Meeting needs under one roof is one of our key principles in our primary care program. And our aim with this was really to try to find more of a systematic approach to testing. So how this works, or how this looks in our program, is beginning at first contact, first intake visit. Typically that happens with a nurse. We aim to have a really non-judgmental, harm reduction focused discussion with folks about substance use, about how and where to access supplies if they're needing, about sexual practices, and about STBBIs. So at that first visit, folks will be screened, and then from that point, they'll be offered to be tested every 3 months. So basically to have standing orders added to their chart. And obviously, between that first visit and the next, in 3 months, if the client has concerns or they've been named a contact or their symptoms or anything like that, we can screen earlier. But that's kind of the plan moving forward. And so the idea is that it's kind of like an opt-out type of scenario. So if folks say, you know what, that's not really, I don't think that's necessary for me, that's absolutely fine. And then at any point in time when they get access care at clinic, they can opt in or out of just having those standing requisitions on their file. And our goal here really isn't to replace those important conversations, because they're important and we want to continue to have those conversations with folks. But like Chris said, within this particular program, we do have folks that we will see pretty consistently, and then we might not see for a period of time. And often when folks are kind of re-engaging or coming back and seeing us again, this might not be a #1 priority on their list of things to take care of in that first visit. And we just know that if that standing order is there, it won't get missed. And that's maybe an opportunity for us to touch on it at the following visit.
You have about 1 minute.
Okay, Chris.
All right. So just rationale. So the automatic testing or more of an opt-out approach to STBBI screening helps with earlier detection potentially, overall decreases stigma and normalizes routine testing and screening for STBBIs, and that's both for patient comfort and also kind of taking away for providers some of that our own biases that we might have for folks that they might not need testing then or might not have been higher risk, and just kind of having that routine in place. Our clients whom we see for OAT see us regularly, and we do quickly develop rapport, which allows for windows opportunity to complete this testing, and then also improve follow-up rates. So when they're coming back, we can manage some of those things a little bit quicker. Next slide.
Perfect. So realistically, our ultimate goal with any client interaction is to meet folks where they're at, to provide wraparound, client-centered, team-based care. We want to work to reduce the stigma around STBBI screening while continuing to foster good therapeutic relationships. And basically, the other thing is we're just striving to ensure that testing isn't falling through the cracks. And that's basically it.
Thank you very much. That was a lot of information, a lot of hard work on your guys' part, and definitely gives us some ideas for sure. So now we are going to move on to Angela Karellis from McGill in Montreal, and she's going to be talking about a strategy for HIV, hepatitis C, syphilis, for at-risk Canadian populations. What's the verdict? Oh, wait a minute, I missed a line there. Sorry, Angela. The first part was evaluation of an innovative AideSmart app-based multiplex point-of-care screening for strategy for HIV, hepatitis C, syphilis, and at-risk Canadian populations. What's the verdict? So with that, I will turn it over to you, Angela, and I will let you know when you're at your 9 minutes.
Thank you so much. Just have everyone confirm if you can hear me and if you can see my slides. Yes, perfect. Thanks so much. All right, so good day, everyone. My name is Angela Karellis. I work at the McGill University Health Centre Research Institute in Montreal. And I am leading a study that evaluates a novel strategy that utilizes an app called AideSmart, which I'll present to you today. The strategy aims to optimize steps from multiplex rapid screening to all the way to linkage in the management of HIV, hepatitis C, and syphilis in Canada. So as we all likely know, the COVID-19 pandemic has disrupted sexually transmitted bloodborne infection services. It has a management of these illnesses very difficult, from screening to retention. Most importantly, decreasing people's access to these services. However, even prior to the pandemic, numerous challenges were experienced when STBBI lab-based screening was performed. For instance, people had to show up for multiple visits for testing to receive their test results, and they were subject to a long turnaround time awaiting these results and to be linked to care. All these elements precipitated loss to follow-up. Collectively, in the STBBI space, we are working towards the achievement of 2030 elimination targets. So UNAIDS has set the 95, 95, 95 targets for HIV, which entail that 95% of HIV infected persons are aware of their infection. Of these, 95% are treated, and of these, 95% are retained in care. For hepatitis and syphilis, a reduction of 90% in incidence is sought. To achieve these goals, there's a need for connected strategies involving a variety of stakeholders to increase access, all while minimizing stigma and anxiety. Thus, we present AideSmart, a portable app or web platform-based rapid screening solution for multiplex technologies. Just by using this app offers multiple benefits. It allows to counsel, educate, screen, test, and rapidly link at-risk patients to treatment within a short turnaround time, as well as keep them engaged in care. It is a strategy offered by healthcare professionals that combines the advantages of point of care and multiplex testing. It allows to simultaneously detect several STBBIs rapidly while facilitating counseling and communication in outreach settings. So the goal of this ongoing study is to evaluate the AideSmart rapid multiplex strategy in key at-risk community populations for feasibility of use and diagnostic accuracy of rapid tests, and for the impact on detection of new infections and treatment linkages. On to the methods. So this is a cross-sectional study. The components of our innovation is the AideSmart app itself, as we can see on the right here, multiplex rapid testing with point-of-care assays, and linkages to care. Specifically speaking to the app itself, AideSmart is a novel rapid screening and counseling strategy, offering both pre- and post-test counseling, providing guidance on multiplex testing to screen for several STBBI simultaneously. It also offers data collection functionalities and optimizes linkages to care. These benefits were designed to be included in the app to keep providers and participants engaged throughout the entire process, from screening to linkage. Here we go. This cross-sectional study is being conducted in 2 sites in Canada, Recap in New Brunswick and Réseau in Quebec. Recruitment has now ended in Quebec, and currently participants are being recruited at Recap. 2 multiplex rapid tests are utilized. The ChemBio dual path platform HIV syphilis rapid test, which is used with the reader, and an investigational Medmira HIV HCV syphilis multiplex rapid test, for which the results are interpreted manually without a reader. Reference standard testing is conducted in local labs and at the national labs for dry blood spot testing. 2 types of blood samples are collected: fingertip blood samples, which are used for the rapid tests and DBS tests, and venous blood to conduct conventional lab-based screening. As the study is still ongoing, we have some preliminary data to present. So far, we have observed high diagnostic accuracy, with the majority of sensitivity and specificity values over 95%. And this can be set between rapid tests and local lab tests, as well as between rapid tests and DBS tests. The majority of participants have completed the strategy, therefore indicating high feasibility. They accepted to undergo the AideSmart strategy, indicating high acceptability, and they communicate there's high satisfaction with the strategy. Also, participants conveyed that they generally preferred rapid testing over conventional testing. They prefer to receive their test results in 1 day as opposed to several days or weeks. And the vast majority would recommend rapid multiplex testing to their friends. The AideSmart strategy had an impact on turnaround time, new infection detection, and linkage to care. The turnaround time for rapid testing was under 15 minutes, and confirmatory test results were generally received in 2 days. For confirmed positive participants, turnaround time to linkage to care pathways was 1 to 3 days, and they were linked to clinics in the city. While these are interim results, we find that this rapid multiplex screen to link strategy is very promising, especially during the COVID-19 pandemic. What we learned is that the AideSmart strategy, together with multiplex rapid tests, fills many screening gaps. It helps screen participants rapidly, initiate confirmatory testing, report test results to the participants, and link them to care. We believe that this strategy has a potential to improve STBBI community engagement and rapid screening in Canada and worldwide. Also, because the study builds upon past AideSmart work, initially funded by Grand Challenges Canada and tested in India, we know it can be applied to various populations. The app was actually reverse innovated for Canada and tested during the pandemic. Finally, we found that the digital strategy can improve communication between various stakeholders, thereby optimizing access and linkages and plugging service delivery gaps. I'd like to thank all those involved in the study, the PI, Dr. Nitika Pampai, our co-PI, Dr. John Kim, the lead investigator at RECAP, Dr. Duncan Webster, as well as all of our colleagues at Réseau RECAP and National Labs. Thank you for your attention.